so we don't forget. Welcome,
Yay.
everyone. I'm glad everyone found the new Zoom link. I know we changed links. This is our first meeting with the new link that we're not having people register ahead of time. People can just join the link and pop on, but we'll give
Oh, how
everyone
fun.
just a little bit to join.
It's nice to see friends from states we know and love. And oh, how fun. This is going to be great. We also have our new meeting time to try to not conflict with other meetings. Oh, cool.
Yes.
Okay, great. Welcome, everybody. Here, I'm going to go off. I'm going to mute myself while you're leading.
No, okay. All right. We will give folks just a little bit longer to join and maybe start here at 2:02. Okay. Well, it is 2:02 on my end, so maybe we can go ahead and get started and folks can continue joining. But welcome everybody. It's the end of March, but this is actually our first Gravity Implementation Affinity group of 2026. So very happy that you all could join us. I know that we had a new Zoom link this year, so thankful that you all were able to come to the right place. I am Demery Henderson. I'll be leading the charge. I'll introduce myself more in just a second if this is your first time here. But really glad that you all could join us. Sarah, Corey, do you want to say a quick hello?
Oh, yeah. So I'm Sarah DeSilvi, co-founder of Gravity and director of terminology. Really excited to listen to what you all have to say today and present some findings. Really super grateful for Demery and our a new additional co-chair who are helping us spearhead this work. And so glad to see so many friends. Corey?
Yeah, hi everyone. I think I know most people here, but
I
I'm Corey
know.
Smith. I'm the technical director for the Gravity Project, and I'm also always excited about implementation because we don't like to build standards that don't get used.
Definitely. Well, thank you both. So before we get started, here is the Gravity Project HL7 antitrust practices. So participants on the call have the responsibility to comply with federal and state antitrust laws. So we just ask you please refrain from any discussion that may be an interference with pricing, services, production, allocation of markets. And we just ask that you do not discuss pricing, others' pricing, costs, terms of sales, or profit margins while on our meeting today.
Oh, here I go. Sorry. I have to
No,
do a
all
better job
good.
being the
Awesome. And here are our housekeeping reminders before we go ahead and really get started. So this meeting is being recorded and it will be available after the meeting on our Confluence page. So we just ask you to mute yourself when you're not actively speaking to eliminate any background noise, and feel free to use the raise hand function to chime in with any questions or comments. And also feel free to use the chat as well. All right, so here is our agenda today. We'll start with some welcome intros and some gravity updates, and then we'll start getting into kind of the bulk of our meeting, which is orientation of the gravity pilot and implementation tiers. And then we'll spend a lot of our time with state level implementation discussion and a review of our survey results. And then we'll wrap up and discuss any next steps. Okay. So, implementation work stream. So, my name is Demery Henderson, like I mentioned, and I am the Grants and Programs Manager here at Civitas Networks for Health. And if you're not familiar with Civitas, we're a nonprofit, mission and member-driven organization, and we're really focused on improving health outcomes for all through health data. And prior to coming to Civitas, I was at EMI Advisors, which is one of the co-founders of the Gravity Project, and there is where I started serving in various roles within the Gravity Project. So in 2021, me and Sarah were just talking about this. It was 2021. I started with the technical work stream as a project coordinator and then served as a senior analyst managing project plans for the first inaugural Gravity pilots in 2022. That was funded by ONC. And then since then, I've transitioned to Civitas and continue my involvement with the Gravity Project. And so Civitas and Gravity have provided technical assistance to the New York eHealth Collaborative since 2024. So I've been the project lead on the Civitas end for that. And then I've also been serving as the implementation workstream project manager since 2024. So that's part of Civitas and Gravity's implementation partnership, which has been so great. So it's been a lot of fun to watch the Gravity implementation workstream evolve over the last 5 years. And also, an exciting announcement is that beginning this year, I will be the implementation workstream co-lead alongside Chris Durant at CVS Health. He wasn't able to join us this afternoon, but he'll be on our calls going forward. And actually, Sarah, Corey, and Chris and myself just had a great meeting earlier this week. So Chris is going to be providing a really fresh perspective to the implementation work stream and providing strategic leadership and facilitation going forward. So he's not able to be on, but he's going to be a great addition, and I'm excited for y'all to meet him. Okay, so if this is your first implementation work stream meeting, it's great to have you. So just wanted to quickly orient everyone, if this is the first call that you're joining of ours. Our goal is really to promote the widespread adoption of and use of Gravity standards. So, like Corey just mentioned, standards are only as good as they are being utilized. So that is really why we're here. And as I mentioned, Civitas and Gravity have been providing technical assistance to New York the past 2-ish years. And there's more state partnerships that are emerging, which is very exciting. So the focus with our affinity group meetings this year is to just really address the key implementation topics that have been identified by the community. And we've heard that you all want more guidance on implementation resources that we have out. So I'll dive deeper into that in a moment, but that will be our focus this year. Okay. And just a quick overview of Gravity, just in case, again, this is anyone's first time with us. So we are a collaborative initiative with the goal of developing consensus-driven data standards to support the collection, use, and exchange of data to address SDOH. And members play a huge role in Gravity being able to develop these important standards. So we just wanted to say thank you so much to all of these fantastic organizations who are really making our work possible here. And then orienting to our three work streams, just so we kind of know where we're situated in the workflow of things. The work streams are an iterative process. So we have terminology, technical, and implementation. And you can see each of the steps in the process there. I kind of like the slides, so we're kind of grounded in how everything works. Then if we go to the next slide, we'll highlight our foundational use cases. So first, documenting social care data at patient and excuse me, at patient and client encounters. And then two, tracking social care interventions to completion. And third, last but not least, gathering and aggregating social care data for uses beyond the point of care. So you have person level activities, and then we start going into population and structural level activities. Okay, so I know this is a very important slide and there's a lot of great information. I won't spend too much time on this because you can join the terminology workstream meetings and nerd out with Sarah if you want to go deeper into all of that. But I just wanted to note the important work that the terminology workstream does in advancing SGOH standards. So you can kind of see our timeline here since how gravity terminology has evolved since 2019. So the terminology workstream is really focused on developing US CDI standards for SDOH. And in 2026, so this year, Gravity is going to be working on legal needs for child maltreatment, mistreatment of non-elder vulnerable adults, physical disability, community access, and access to primary care. And those are domains that are identified by our members and by the community that joined the terminology workstream calls. So if you want to learn more about that, Sarah will be a fantastic point of contact to reach out to. And we also have we have the technical work stream, and that focus is really on the development of the Fire IG. Gravity's Fire IG is the SGOH clinical care IG, so you might hear it referred to as that, and that is the Gravity IG. And it provides the framework to support the social risk domains. And the STOH Clinical Care IG recently published STU 3.0, which is very, very exciting. So congrats to Corey and the team. And there is new artifacts that are out to support the new use cases. So the artifacts that were just recently incorporated into STU 3.0 are healthcare service for referral management, capacity status, observation enrollment status, program enrollment status, and healthcare service capacity status. And you can learn more about that at the technical workstream meetings on Wednesdays. So just quick Gravity announcements before we pivot back to implementation. So as I mentioned, the technical workstream meetings are bi-weekly on Wednesdays, and that's really focused on ballot reconciliation. And then Sarah leads the work with terminology that they're working on the spring 2026 domains. So as I mentioned, those are listed there. But yeah, there's also the HCPC resubmissions that they're working on. The V2 release for service classification is planned for early this summer, and program concepts are going to be released. Sarah, I'm not sure, released March 2026. Have those come out yet? I know there's still a few days left in the month of March.
Should have said released as opposed to release. Yeah, they're out and
Got
live
it.
and ready. It's very exciting.
Awesome. Very exciting. And Lucy, I see your hand raised.
Yeah, coding for food resubmissions. What does resubmissions mean? Did you already submit and these are revised or what?
Yeah. Yeah, I can lean into that. So we did submit as part of our 2024 and 2025 work. And then they weren't accepted in the first round, which is often customary with CMS and HCPCS. So we're resubmitting and we have some revised submissions, and it's particularly appropriate given the focus on food as medicine at this moment in time. So we expect success this time round. It's very normal to have to submit and resubmit when you're looking for HCPCS. And so we kind of expected that.
That's terrific. Thank you. I think HCPCS being a new target for Gravity is really significant because
Yeah,
there are other realms where this could come up.
yeah,
Thank
this is a
you.
primary finding of need from our member-led payment and reporting discovery in 2024.
Right,
Yeah.
exactly. Thank
Mhm.
you.
All right. Thank you, Lucy. Appreciate that question. Um, so orienting back to kind of implementation, in 2023, Gravity and Civitas led a social care co-design activity with the support of the Robert Wood Johnson Foundation. And this was a six-session webinar focused on soliciting, synthesizing, and documenting social care and community-based organization feedback to inform Gravity data standards. So we really wanted to, that was something we had heard a lot from the Gravity community, is incorporating more of that CBO feedback. So the social care co-design was a fantastic way for us to incorporate that. And it really provided critical information and helped inform the STU3 and enhance terminology standards. Um, so anything else to add, Sarah or Corey, on that front as we continue moving on? Awesome. Okay. So to start our conversation, before we do this, I know it wants to be a discussion, so I'll stop talking here shortly, but just wanted to orient everyone to the Gravity implementation tiers. So this was first developed, I believe, back in 2022 with the first Gravity pilots, so it's been a little bit. But before I review the tiers, I just wanted to call out that implementation does start before tier one, and readiness is very essential. So we do have a Gravity implementation readiness assessment that we can share in follow-up. But I wanted to go over and just orient everyone to our three-tiered piloting approach that has been out for a while, but I know things have changed and maybe we haven't touched on it as much as we should in recent years in the affinity group meetings here. But I thought this would be a good time considering the feedback that we got from the survey, which I'll dive into in just a little bit. So for tier one, that includes establishing the information infrastructure and any exchange of information, or maybe not at all, but that is the minimum requirement for Gravity pilots, is starting with tier one. And then tier two is the electronic information exchange. So this could be done by CCDA, HL7V2, direct transport. It doesn't necessarily have to be the fire exchange. And then tier three would be the complete implementation of the Gravity clinical care fire IG, the SDOH data model, and using the exchange standards. So that is the primary focus of like where our fire pilots are. And so we recognize that the lines between each tier are blurry a lot of the time with the terminology and the technical standards. We just wanted to acknowledge that some organizations might be tier one for one category and maybe tier two for another, tier three for, terminology or technical, but the tiers are blurry. So there might be like a tier 1.5, tier 2.5. So we'll be going into that in a little bit. Okay. And so today we really wanted to focus on the state implementation of gravity standards, kind of using the three-tiered pilot implementation approach as our foundational framework. So Sarah, do you want to review this slide with the
I'm
implementation
here for it.
drivers?
And you're doing it. You're killing it. Killing it, Demery. All right. So, we actually produced a blog about this earlier on this year with HL7, but and Demery will go more into that later in the slide about why every single year we kind of take a pulse on where we are with implementation. We're definitely not in the same place when Demery was leading our pilot efforts in 2021, right? So moving beyond piloting to implementation. So there's multiple national and state initiatives that we recognize that either directly reference gravity standards or create use cases for gravity alignment early by design, whether it be USCDI, NCQA, CMET, HRSN screening requirements and recommendations, digital quality measure roadmap alignment, state digital and SDOH data strategies and frameworks and initiatives. And so, in line with this, to get ahead early and by design, many states are building past implementing gravity terminology and technical standards into their efforts. Um, Amazing Demery mentioned our wonderful relationship with New York is very intentional toward this point, like hardwiring gravity, SUHCCIG, and terminology into the pathway for the waiver. But you can see states in implementing referencing gravity and guidance and regulation all across the country. And this is an insufficient map. Our members probably on the call today could tell us all kinds of additional things. But we know New York has mentioned us, Nebraska's written us in, Michigan, of course, had. I see friends from Michigan here, so nice to see you, Elizabeth. We know the Colorado, Koshi has, and more states emerge regularly. Every single month, we found an additional state that's referenced gravity, and either as a requirement for RFPs or directly into state policy initiatives. And so this is really the part of the focus of Gravity in 2025, 2026, and beyond is supporting states in this widespread adoption and use of Gravity standards. And it's the topic for today's a focus of today's survey and meeting. Demery, any other things from your wise New York seat?
No, just really appreciative. I think you covered it. Really appreciative of our partnership with New York. They've been doing fantastic work over
Mhm.
there through the 1115 Medicaid waiver and their social care network. So glad. I don't think anyone from New
Yeah.
York is on, but
I saw Rachel's here.
oh, Rachel.
Well,
Oh,
she was here. I
Rachel.
mean, she's a little
Yes.
confusing because yeah. But
She used to
yes,
be part of
she
the
used to
New
be
York team.
nice. Hi.
Yep. So good. So good to see
Yeah.
you on.
Yeah, and then if you were at HIMSS, you can see that Demery and Jess actually presented on New York and Gravity at the HL7 booth. All right, so here we go into the survey, Demery. Are you ready? In the
All right,
conversation?
I'm ready.
Okay.
Okay.
I'm gonna stop talking now. Go.
No, all good. So, yes. So, as we mentioned, I've been kind of alluding to the survey that we've done and that we're going to be talking about today. So, we deployed a survey via our Gravity listserv. So, happy to share the link if you happen to not receive it. We definitely want as many responses because this is going to be informing our work throughout 2026 for the affinity groups. But like Sarah was saying, each year we really aim to shape our efforts into what is needed at the time, and we recognize it's always evolving. So we feel like at the beginning of each year is a good time to sit back and reflect on where the community is and what you all are saying that you need some assistance with. So we know that everyone can't attend these IAG calls. So we sent a survey out to try to better understand what's needed and what we as a Gravity project can assist the community with. So, alas, a survey. So our survey began with assessing who was responding to the survey. So we got 12 responses so far, and again, we want this to continue evolving over time. But we got a fairly diverse sample of respondents. So we had some combination of state leadership, we had HIEs, vendors and platforms. We got some respondents from Medicaid, CCBHC, consultants, associations. We had a health plan, a nonprofit, CBO, and NGO. And then in a follow-up question on the survey, we asked, what are the drivers that lead you and your organization to align with and implement gravity standards? And so the answers we received included public and population health, such as data capture and aggregation, normalized and consolidated reporting. There was also mention of financial investment of services. And like me and Sarah were just talking about, we know that's being included in a lot of statewide regulations. There's also a mention of implementation assistance from the survey, as well as referral standardization from different organizations and organization types. They listed out healthcare, CBO, referral platform and vendors, and then aligning with the organization mission. So we saw that someone had noted that their organization is also deeply committed to addressing the needs of the populations that they serve. So that was what we had heard. And then we also asked briefly, what is working well when implementing the gravity standards? So here you can see what we've heard is working well. These are just directly taken from the survey that we put out. So we have terminology alignment, terminology supporting the NCQA HEDIS measures, and as well as some more. I won't read them all off the top here, but it was important to see what is working well so that we have kind of a baseline understanding of where the community is and maybe what is already succeeding we don't need to focus on right now. So we can shift our focus in really listening to the feedback of what is some gaps in the implementation resources that the community is in need of. So that leads us into what enhancements to gravity standards are needed to achieve the mission of interoperable exchange of information between the health and social care entities. So we really wanted to hear about refinement to gravity standards, the improvement of implementation guidance, or maybe even the creation of new standards. We wanted to hear and get the information from the community. And I see in the chat. The driver's questions are, or maybe I already answered that.
Yeah, Lucy asked a question that was the second
Perfect.
question of the survey. So I was like, oh, it's coming.
Good timing, Lucy. I'm glad that we were able to be in sync with that.
Lucy always does that. She's always, I feel like that's the norm with Lucy.
Absolutely. All right, perfect. So, some common themes in the responses that we were hearing from the survey responses that we've heard so far is that enhancements would be beneficial. So, some folks have pointed out that automated consent that accommodates 42 CFR Part 2, as well as referral routing and CBO screening standards would be helpful. And then there was also a comment on pacing and slowing down the development of new standards until the ecosystem is better equipped to evaluate and implement what is already existing. So that was really beneficial feedback to hear. I know speaking for myself, but maybe Sarah and Corey as well. I know that we're so close to this work and we're always trying to innovate and come up with new things and improve the standards, but if the community isn't ready, it is important to also, slow down and evaluate where people are and how we can assist in using the information that we already have. So I don't know, Corey or Sarah, if you have anything else to add to that. I don't want to speak for everybody, but I thought that was very important information to hear.
Corey
Yeah,
has
I would just say,
probably, yeah, go for it.
no, I just think there is a tension, right? There
Mhm.
are those that want us to go faster and do more, and there are those that, you know, are feel that even the existence of standards, even if they're not mandated, still create a risk of harming or putting undue burden on stakeholders who are already spread very thinly and don't benefit from the same resources that maybe healthcare has for many years. So it is a tension, and I think we'll have to continue to navigate how we manage that.
Definitely.
Even, and I
Thank
want to
you.
note, even this week we came up with some innovative solutions to try to, like, we're always here for try to figure out how we can work in the middle and create standards that can be used but that are not mandated and evaluate what we're rolling out according to where implementers are. So this question was very well received and timely, I think, and we're grateful for it.
Absolutely. All right. And then another theme that we also heard was around piloting and implementation partnerships. So we heard that there is a need for longitudinal implementation partnerships that are aligned with at specific drivers. So health systems, payers, vendors, NCQA, state waivers, classification. And I wish Chris was on. I'm sure that Sarah and Corey could say the same because we had a fantastic internal discussion earlier this week. But a big question is there a gap in knowledge and information in the UI UE experience or platform design? Or is there organizational change management that needs to be done, like feasibility and cost as well, to continue the implementation of these standards? So that is another theme that we had heard as well. And then about guidance. So, part of the survey responses that we received, we also heard that guidance focused on specific stages of implementation and use cases would be really helpful and just meeting implementers where they are. So, how I referenced the three-tiered piloting approach. We thought that was a great way that we could maybe bring back some old material that we've developed and really focus back and reground ourselves in that. So we already have material developed for that, like the readiness assessment, the implementation tiers, and the use cases. So we just need to highlight and provide education on the content that we already have developed. So um, the fire observation data expectations for EHRs is another thing that we had heard as well. So
And I, sorry
thought
to
that was
pipe in,
very
Debbie,
helpful.
one
Mhm.
thing that you and I identified early is trying to get a standard method for capturing what types of implementation guidance implementers desire. So over the course of the next week or so, we're going to be deploying like a standardized method within the implementation area on the Confluence for collecting and curating desires for specific implementation guidance, again, across those four tiers, really readiness, tier one, tier two, tier three, so that we can support you all. And we recognize that with tier two, implementation guidance might be in collaboration for it. Like it might be like, for instance, Brian's on the call. It might be Gravity terminology over direct, right? And so if there are opportunities to collaborate with our other friends in the SDO space, we're totally in for it. And so we're hoping to collate and curate that information and implementation guidance that would be helpful in a standard method over the course of the next year.
Definitely. And I see Lucy's question in the chat here. Which state agencies received the survey? So we put it out to the Gravity listserv and then also circulated it with the Civitas SDOH and interoperability work group. But it will be posted on the Gravity Confluence. It's going to be public going forward. This is just kind of where we started was with the Gravity listserv and then the Civitas SDOH and interoperability work group. So it was folks in the public health department and Medicaid, but we're working on expanding that as well. So as many folks in state that could, yeah, no problem. And I see Skylar in the chat. We're interested in the service classification and directory, as well as the program documentation use cases. That is very helpful feedback going forward. Yes, and Sarah noted that the survey was also posted on LinkedIn. Fantastic. Okay, so I promise I will stop yapping here in just a moment. So just a few more questions to go over the results of the survey with you all. So we also asked a question in the survey about gravity's scope and whether what additional ecosystem enhancements are needed to complete gravity's mission. So this really provided a wealth of information and opportunities for advocacy. So we heard a lot about consent and privacy standards, the technical infrastructure being a big challenge, and financial investments as part of the big three here that we heard about. And then there was additional comments on the expansion of corporate support and just general education on the SGH standards. So that was very helpful insight that we heard from the survey as well. So all in all, the survey learnings and themes that we heard, we just wanted to quickly, deeply thank everybody who submitted and contributed to the survey so far. It was really valuable for Sarah, Corey, and Chris and I to go back and really hear from the community. So we heard that it sounds like specific guidance on enhancements to terminology and technical deliverables will best come through intentional longitudinal implementation partnerships or communities of practice. So we're happy to adapt and pivot the IAG strategy to better suit the needs of the community, and additionally the implementation guidance across the ecosystem to help truly leverage the full benefits that the gravity standards create. Okay. So that brings us into our roundtable discussion. So we really want to hear from all of you. So the survey was a great starting point to help give us a sense of direction of where the community is and what you all are looking for. But we wrote down a few leading questions just to help get the discussion started. So I'm not sure if there's reactions to the survey and what we've presented on thus far, or if any of these questions are sparking initial thoughts, but would love to hear from you all via the chat, or if you want to raise your hand, happy to have you come off of mute. And we would love to hear kind of reactions, thoughts about where gravity is going in the future and what we can best assist with. I see the chat is
I know.
full.
It's just me.
Do you have, so Brian, you put
Thanks,
something in the
Brian.
chat. Are you going to talk about it out loud or you feel like you're not ready?
Oh, this is something we've been working on for, at this point now, years. But we are finally at the point where we have the necessary direct trust standard, the metadata and payloads IG, completed, which would allow us to create FHIR attachments, native FHIR attachments to direct secure messages. That was what was necessary for us to actually be able to take the gravity referral spec, the SDOH clinical care IG, and transform it, if you will, into a FHIR document as an attachment to a direct secure message, so that a hospital system, a healthcare system, could create a FHIR referral in their FHIR server that a coordinating platform or an intermediary, like an area agency on aging, could interact with the FHIR server on the healthcare system to receive, if you will. Imagine me doing air quotes here. Maybe I should just turn on my camera. To receive a FHIR referral, and then transform the resources associated with that FHIR referral, the task, the service request, the patient resource, the condition goal, et cetera, et cetera, et cetera, into a FHIR document that has each of those different resources in it, that would then become an attachment to a direct secure message, which is really just an SMTP email message with the associated direct trust framework, i.e., we know who the recipient is, we know who the sender is, etc. But it's just an email message. And send that email message along to a CBO that either doesn't have support for FHIR directly, or maybe isn't allowed to even interact with the FHIR server up on the hospital system. So this is kind of a way for us to translate a healthcare system's gravity referral into something that a smaller CBO out in the community could receive and then be able to accept. through various mechanisms we're building into our IG, that in turn would percolate back up through the intermediary, through the area agents and aging, for instance, that would then turn it back into the necessary fire transactions with the healthcare system. So we're trying to figure out how do we turn around and take the great work that we've already done here on the Gravity Project and make it accessible to folks way out in the field that may not actually be able to interact with a gravity referral directly, but could do so through some kind of a translation of the gravity referral into something that they can deal with.
Thank you, Brian. That's a very good example, it seems, of that 2.5, right? So our original original tiers were like, there's a two, and there's a two, there's a three. But that's a good example of something in the middle that is achieving the needs of interoperability, but not specifically in this or that.
Looks like
Um,
I'm about to be corrected by Courtney.
I know.
What did I
And then
get
I have a
wrong,
question.
Courtney?
I have a question on question number two. So Courtney, do you want to go? And then we can go, I have another question for the community.
Yeah, no, all I was going to say is to pile on to what Brian had to say, know that what we see amongst our network and our downstream. So, our network is large, representing the entire country, and they contract with 20,000 local aging service providers. Many of them have the direct secure messaging capabilities, but they are not fire enabled.
Hmm.
So, this becomes a really important contribution to
Hmm.
everybody being able to play ball. So,
Love
just
it.
wanted to add that.
Thank
And
you.
I should
So,
give credit where credit is due, though I designed this for Open City Labs. This concept was actually implemented by Open City Labs 4 years ago, at
yeah.
least 5 years ago, about the same time that we were originally doing the implementation of the Firebase SDOH Clinical Care IG. Way, 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 way. We were one of the very first companies to do an implementation of it. And at the same time, we recognized that there was going to be this problem. How do we get these great fire referrals out to folks that don't have fire?
Hmm.
So we implemented it,
Thank you, Brian.
and we're only now getting around to the point where we can turn it into a standard.
Amazing. Um, Thank you so much for your work and collaboration, Brian. I have a question regarding, I see, Demery, I hope it's okay for me to pop in.
Yeah,
I see
please do.
state friends. I see Michael from Maine. I see Elizabeth from Michigan. I see lots of platforms and HIT entities that help support state level implementations. So regarding the focus, so what specific implementation guidance would be most beneficial for you all to complete your state level initiatives? Again, I tried to call you all in as opposed to just one of you. Are there specific things that you need to complete the mission that we would be able to support? What pain points are you discovering? Like, how can we, regarding statewide implementation and rural health transformation, what trends are you seeing? We would love to hear from you. Sorry to call you in. Any thoughts? Even our vendors, our platform friends, Rachel, Jaffer.
Yes, sir. I'll say in Maine, I think we're still kind of exploring this
Mm-hmm.
and trying to
Mm-hmm.
figure out where it fits in. I think we have a community information exchange pilot that's starting, and there is some funding in the RHTP going towards it. And so I think that might be one avenue where we start to explore it. And then I think there might be just other things that grow out of our HTTP that aren't really identified now, but might SDOH and or what gravity's doing may fit in as those things evolve and identify um, exactly sort of what their goals are. And that's part of the reason I wanted to attend today was try to get a sense of where things are and then where I can look for entry points to kind of bring in or put input this sort of information.
Awesome. Thank you. And then we have, so then in term, like, so we have Mike and we have Elizabeth from Michigan. Can I call Michigan in? I'm so sorry. It's a hazard to have me know you. Hi, Liz. Sorry.
Hi. Thank
Hi.
you. Well, I just would build on what Michael was saying in terms of the opportunity with the Rural Health Transformation Program. Michigan did identify interoperability in action as one of our four pillars, and so we're working through some pre-implementation activities right now to make sure that we are aligning with existing infrastructure and really supporting our rural communities in ways that make sense for them. But I know Dr. Klinkman, we were just having a little bit of a side chat around some of potential pilot projects or adjustments to existing pilot work that, we're also thinking about, of course. Um, so all that to say, more to come. Lots to discover together. But thank you for this space. It's really helpful to just hear the latest from you all and what other folks are thinking.
Yeah, and then I hope you're a good example of writing an email and me trying to get you what you needed in like that we had to date. Sometimes implementation guidance is an email to gravityproject at hl7.org. And you're like, I have this problem, right? And we're like, well, we don't have a formal solution, but we have this. And it actually became, Liz, a formal solution with the Foodist medicine SNOMED terminology being posted on the Coding for Food Confluence page as a halfway point until as we await those HICPIC concepts. So it's great to hear from Michigan. And then, Mike, do you have anything further to say from the Michigan side?
Just a couple things. I think the work that Brian mentioned is stuff that we're trying to make go in Michigan. We have all sorts of community care hubs, community social care networks that are in various stages of evolution and survival. So we're trying to figure out the simplest, most flexible ways for each of them to build their infrastructures. And so like Elizabeth said, we're focusing really hard on interoperability and infrastructure, but I think that we're going to have to make sure that we have pathways of exchange that include something that is not yet fully FHIR. So
Mhm.
I think that was really promising here, and I think that's a big step forward.
Awesome. And so I wonder if there's a combined, given that Corey was mentioning the service, like, what we've already built into the IG, the direct referral light and indirect referral light. I wonder if there's a way to like kind of crosswalk the different options and like create a joint implementation guidance of all the possibilities, both directly within the IG and outside of the IG for engaging and meeting CBOs where they are.
Yeah, I think that's a
Um,
great idea.
yeah.
And the other thing is we've got in some communities we have network of networks that we need to connect to, and inside the routing of any referral traffic, there's going to be a large potential for misrouting and erroneous routing between groups that kind of handle a portion of a population. And so that's the direct indirect referral stuff. That's the how do you bounce it when it has to bounce to some other primary recipient of a request. And we haven't, in Gravity, we haven't dug really deep into that. But I know
Mhm.
that whatever we design is going to have to somehow accommodate that without a lot of horsepower, I think. So
That reminds me of some of the flow diagram work we're doing in ST 3.0, trying to make sure that we
yeah,
represent. Yeah.
yes. And
Yeah.
and
I
when
can
we've
hear
tried to do
Lisa,
that flow
Nicolu in the
diagramming,
back of my
yeah,
head.
yeah, and putting things in the right sequence is
Mhm.
hard. And I'm realizing increasingly that there probably is no single sequence
Well,
here
there
that
is,
will.
yes, that's the thing is like every community creates their own community, right?
And so the
Um,
challenge is going to be
yeah,
figuring out how to make those sequences also flexible, and that's going to be fun.
that sounds it does sound like fun. So we have Courtney and Lucy, and then I have another direct question. So Courtney.
Yeah, I think, thinking that through, and Sarah thinking through some of the other things we've seen that kind of back up all the way to Demery and Sarah, that social care co-design up until today. I think one of the things that is probably very hard for the larger Gravity community is that, all of these community-based organizations are not the same.
Mhm.
And so a referral to one could be very different than a referral to a next one in terms of their capacity,
Mhm.
um, what they're doing, how they're digesting it, as well as what their responsibilities are. And, when Mike talks about networks of networks, so when you contemplate that, it's very different to refer in to a AAA because they have requirements and obligations, as well as when a AAA takes somebody, they're typically are doing a whole care plan and the whole care rather
Mhm.
than one CBO, it may be just meals. So I think one of the things that could be very helpful to Gravity and the Gravity community is maybe on the front end, as you're dealing with the CBO, understanding what kind of CBO it is. I don't know if there's
Mhm.
a way to do
Mhm.
a classification there.
Yeah.
Because I think part of the problem with referrals when I look at this is that from the front end of Gravity, I think there was an expectation of, okay, we're going to help people refer through to the service that they need. And that's not necessarily the way a lot of funders and services are organized.
Well, isn't that's Courtney, we should just make a holistic assessment service within the service classification. Like that sounds brilliant. Like
You
I
know, are,
so you
are
could
you
tag,
sir are you
yeah.
providing a single service?
Yeah.
Or are you more holistic and you kind of, own, or your portfolio is a much larger funding stream
Hmm.
that we're looking at broader care. I think that could potentially help this whole process.
Yeah. That makes a lot of sense to me. And it kind of, you and I had a follow-up conversation we were supposed to have, but that was like one of the things I wanted to talk to you about. So the fact that you're bringing it up right today is fantastic. It'd be great if we could identify and then Mike is okay, yes, Mike's not, but great if we could identify organizations that have the capacity to offer or the skill set, the knowledge, the expertise, Courtney, because it requires all of those things, right? To offer that, that deeper assessment that we know is the gold
Well,
standard.
well, and it's not just that, but I would say entities that are quite frankly designated.
Hmm.
I mean,
Hmm.
like old AAA's have to do Older Americans Act, so that
Hmm.
brings with it certain
Hmm.
capacities and certain designations.
Hmm.
A good example, let's take in states. You have on the families and children's side entities that have the state block grants.
Hmm.
They too
Exactly.
have large portfolios
Hmm.
versus a an organization that is, again, I go to nutrition because it's an easy one, that is doing nutrition, period. That's what they do. Or providing a ride, because when folks are making these auto referrals, it's sometimes they don't understand the complexity of the CBOs being different. And I was thinking a little bit about the capacity management, Sarah. For some entities, they probably would really love to have capacity management ping, because somebody would say, can you take our client? And they're going to respond, no, we've given out all of our meals.
Hmm.
Whereas you ask an entity with a state block grant program, or you ask us, do you have capacity? Well, that just takes you down a rabbit hole because we can't answer that until
Yeah,
we do
yeah.
the full assessment.
I hear you.
So I think the landscape and all the stakeholders understanding that there, maybe, I don't know, maybe there's two or three classifications
Hmm.
of entities
Hmm.
and what that means when you refer to them.
I hear you.
Understand who you're referring to. And Mike, does that begin to get at some of the issues you see in Michigan?
Yes, partly. I think that it's more than a unidimensional sort, and
Hmm.
that's why we've struggled to figure this out because there There are subnetworks that relate to a single domain and have very complex implementations and connections. There are sort of coordinating entity based community organizations. There are the single service organizations, and they do different stuff. And I don't think we've got it right just with a unidimensional sort. So, but this conversation is a terrific starting point, and we don't want to make it too complicated. Yeah.
Yeah, and I'd like to fold as much of it into enriching the methods we already know are being utilized by CBOs,
Yeah.
especially. So if we,
Yes.
like, so if we already have like the service classification work that is, where CBOs, for the sake of integration and navigation and connection to services, are identifying themselves with specific tags, it'd be great it was still one place, like 211
Yeah.
HSAS being part of that. That would, I don't, again, Courtney, if I learned anything from you, I do not want to make a CBO do something extra.
Well, we appreciate that. And real quickly, Rob, I see your mention in the chat. And what I would say is it's not about rolling up into a category of a provider. It's that different there's different levels of provide there's providers that have very large portfolios and are required to do several portions of the care. It can start from information referral to assessment to care plan to service provision and care coordination, where others are just providing one service. And so it's more so understanding for a referring entity what kind of entity am I referring into? Because that comes with it a lot of requirements and obligations. And sometimes that comes with it the complications or providing whole person care. It just depends. But I think that there has to be some level of understanding that all these CBOs aren't the same. So to try and refer into all of them the same way and expect that you're going to get the same response that's not happening. I mean, I can just tell you.
Yeah.
So anyhow, I'll be quiet.
Thank you, Courtney. And again, that's partly what we're trying to do in other areas. So folding it in. We have a question from Lucy, and I have one more question, Demery, just before it's almost
Mhm.
time, my friend. Woo, that was an hour. Okay. So Lucy, you have your hand up?
Yeah, I was just wondering where is Alana when we need her?
Oh, I know.
Hasn't 211 been dealing with taxonomy for the last 30 or 40 years? So
Yeah, so that's
I'm
that's who
sure
we
there's
work
a
with the
foundation
yeah.
to build on here. But the reason I raised my hand is that I'm wondering whether anybody can think, not at this moment, but sometime, of funders, national foundations who are capable of investing in capacity in multiple states for similar goals or outcomes, because going state by state obviously is where everybody starts, but from a more strategic, long-term, longitudinal perspective, I'm wondering about foundation support, multi-state, for either certain kinds of agencies or certain kinds of outcomes to start this investing in capacity now that they would have a sense that there's a standard way to do this.
I know, what if we all pooled our RHT funds, Lucy? All right, I have one more question. Uh, Lucy's always thinking big, and I appreciate it about her. So before we leave, because we're almost at the end, like HIT friends, like find help, unite us, because you do so many state level implementations, like statewide. Any final thoughts on implementation guidance needed, or or field thoughts before we close? Calling you in. Danger of
Hi,
attending.
hi everyone. Just really quickly, I was gonna say, one of our wonderful solutions engineering folks did a great presentation at HIMSS on this, and the work that we are doing. and a lot of it being very reflective of the Gravity project because of the need for like the data standardization and leveraging of some of those very impactful measurements here for the rural health. I was gonna say we're getting a blog up pretty momentarily on some of these items, so I'm happy to send that out and um, maybe Sarah, we could get that circulated. But I know a lot of us are just seeing sort of right now how we can kind of like support these conversations because they are so important and like how we can think about standardization, especially
Mhm.
across all of the states and
Mhm.
the very to kind of the points made in this conversation, network of networks,
Mhm.
the different programs, how different states sort of look, and what kind of Gravity brings together there.
Mhm.
So,
Awesome. Thank you, Rachel. We
of
love that
course.
blog. And then, Joffrey, you want to take us home?
Hey, thanks, Sarah.
Hi.
Yeah, good to hear everybody's voices and see some of you. So, um, I would say that two things. One, we're hosting 24 state summits this year. We've
Mm.
held several already, and any of y'all are welcome, to join those summits. You can certainly reach out to me to get the full lists, and then, we're covering as many as we can this year. We're bringing together government officials, legislators, Medicaid directors, organizations doing this work. And Gravity and the standards work is a core part of every summit, every presentation. And we're educating and we're teaching not
Wow.
only CBOs, but also hospitals and plans and government agencies how they can incorporate many of these standards in a way that doesn't interfere in how they do their job. Meaning, for a lot of CBOs, a lot of the standards mapping, including codes, they just live behind the scenes. They never have to know what a LOINC code is or what a HCPCS code is and so forth. And I think that's what trips up so many groups is it looks like a whole new healthcare world when in reality, it's really not necessarily for them, although it can help them with grant funding and understanding of data. But at the end of the day, we have to do translation, of why this work's important and why it can help them in the long run. So that's maybe a one plug that I'll make for today.
So wherever you are, thank you so much, Joffer. Like that just makes me, because Gravity can't be everywhere, right? The team, but you are all everywhere, right? So if there's any mission for IAG and implementation in 2026 and beyond is ensuring that the feedback loops happen into the Gravity ecosystem so that we can, do this work well and well informed. And so hopefully the IAG will be that kind of space and we'll develop the materials in the implementation confluence to glean that kind of wisdom and standard methods. And then I think we're almost at time, but Demery, back to you and Jonathan, do you want to take us with your last statement before we move to the next thing?
I just wanted to say to Joffer's point, I think that if you educate the market and allow them to tell you how they're going to use it, then you're not focusing on standardizing a process that they can't implement. And once they do that, that will actually inform the process of how you continue to innovate the solutions to make them more applicable for the people who choose to use them.
Thank you, Jonathan. Yeah, that's that's really helpful insight. I appreciate that.
Woo woo!
Okay.
Go Demery!
Well, that was quite the whirlwind. Thank you so much, everyone, again for joining today. I know we shortened these meetings from 90 minutes down to just an hour, so thank you all for taking the time and having this robust conversation with us for our first meeting of 2026. So we'll be
Oh,
reconnecting again in May. I believe it is May 28th, so right after Memorial Day, right into the summertime, which is exciting. I know I'm over winter, but um, again, thank you all so much for this conversation. I put the link to our survey in the chat there. So if you would like to answer those questions, that would be really helpful. They're going to help guide and better inform the affinity group meetings going forward this year. So your input would be very appreciated. And again, thank you so much. Our recording will be put on our Confluence at the end, and stay tuned for the meeting materials following the meeting. And if you have any questions, feel free to reach out to myself, Sarah, Corey, Corinne. We'll be able to point in the right direction. So thank you all for joining us this afternoon. Have a great rest of your day.
Thank you, Demery. Thank you,
Take care,
everybody.
everyone. Thanks for joining us. Take care.
Thank you.
Thanks.